Right now, somewhere in America, a person over 60 is signing a surgical consent form. They have been told they need the operation. They trust their physician. They are doing what they are told, and based on the published evidence, there is a significant chance they do not need it. A landmark analysis published in JAMA Internal Medicine estimated that between 10 and 30% of common surgical procedures performed in the United States are unnecessary, meaning they provide no clinically meaningful benefit over non-surgical alternatives. For adults over 60, that number carries a specific weight that it does not carry for a 40-year-old. Because after 60, the biological cost of an unnecessary surgery is not the same, it is higher. Measurably documented, significantly higher. And there are 5 specific operations that are being recommended to seniors every single day. Operations for which the peer-reviewed evidence is either deeply conflicted or unambiguously clear that they do not work better than alternatives. I am going to walk you through all 5. The mechanism, the research, the alternatives, and the questions you need to ask before you ever sign another consent form. Stay with me, because at the end of this video, I am going to reveal a protocol that the surgical industry has zero financial incentive to discuss with you. A protocol that, in multiple published clinical trials, caused patients to improve so dramatically during the preparation period that they no longer needed the surgery at all. My name is Dr. Chandler. I specialize in gerontology, the science of how the aging body responds to medical intervention, and how to protect seniors from interventions that cause more harm than benefit. I want to be direct with you from the start. I am not anti-surgery. Surgery saves lives. I have seen it save lives. When the indication is genuine and the evidence is clear, an operation is a gift. What I am opposed to is unnecessary surgery on aging bodies. Because the biological consequences of an unnecessary procedure in a 65-year-old body are categorically different from the consequences in a 40-year-old body. A 2018 study published in the British Journal of Surgery, Munazinghi and colleagues, documented that postoperative complication rates increase by an average of 2.5% per decade of age, with the steepest acceleration occurring after 65. A separate analysis in the Journal of the American College of Surgeons confirmed that postoperative cognitive dysfunction, measurable cognitive decline following anesthesia, affects up to 26% of adults over 65 after major surgery, compared to less than 4% of adults under 50. That is not a rounding error. That is a 6-fold difference. And the system that profits from surgical volume has no structural incentive to lead with that number. I do. Here is what the research confirms about what happens inside a senior's body every time a surgical incision is made. After 60, fibroblast function, the cellular machinery that rebuilds tissue after surgical trauma, operates at measurably reduced capacity. A study published in Aging Cell Journal confirmed that fibroblasts in adults over 65 produce collagen at approximately 60% of the rate seen in younger adults. What that means practically: wounds take longer to close, scar tissue forms more densely, and the fibrin strands that create internal adhesions, the bands between organs that cause chronic pain and digestive disruption, are cleared more slowly by the body's fibrinolytic system. Every surgical incision in a senior body is a biological event with a longer tail and a more significant footprint than the same incision in a younger body. Now, multiply that by an operation that was not necessary in the first place. The question is never just, can I survive this surgery? The question is, what does my body look like on the inside 6 months after an operation I did not need? Let me show you the 5 operations where that question matters most. Operation 1. Knee arthroscopy. For osteoarthritis, the surgery that performs no better than a fake operation. Most people believe that if a surgeon enters their knee joint, cleans out the damaged cartilage, and washes the joint space, the knee will function better afterward. Here is what the most rigorous trials in surgical research history say about that belief. In 2002, researcher J. Bruce Moseley and colleagues at the Houston VA Medical Center published a landmark randomized controlled trial in the New England Journal of Medicine. They divided patients with osteoarthritic knee pain into 3 groups: One group received a full arthroscopic procedure, one group received a partial procedure, and the third group received sham surgery. Real incisions in the skin, real surgical instruments touching the knee, real recovery protocol, but no actual arthroscopic work inside the joint. At every follow-up point, 2 weeks, 6 months, 1 year, 2 years, all three groups reported identical improvements in pain and function. The patients who received the fake surgery did just as well as the patients who received the real one. In 2008, a second major trial published in the New England Journal of Medicine, Kirkley and colleagues, confirmed these findings in a Canadian cohort, again showing that arthroscopic surgery plus physical therapy produced outcomes no better than physical therapy alone. For seniors specifically, the American Academy of Orthopedic Surgeons updated its clinical practice guidelines to classify arthroscopic knee lavage and debridement for osteoarthritis as strongly not recommended, their highest level of recommendation against a procedure. And yet, according to data from the American Journal of Sports Medicine, hundreds of thousands of these procedures are still performed annually in the United States, many on adults over 60 whose osteoarthritis makes them the least likely to benefit. Here is what actually works. A supervised exercise program targeting quadriceps and hip abductor strengthening, published in the British Journal of Sports Medicine, produces pain reduction and functional improvement equivalent to surgical outcomes at 12 months without any surgical risk. For seniors specifically, aquatic exercise, walking and resistance work in a pool eliminates joint loading while maintaining the muscle-building stimulus. A 2019 Cochrane review confirmed aquatic exercise produces clinically significant improvements in osteoarthritic knee pain in adults over 60. Before agreeing to knee arthroscopy for osteoarthritis, ask your surgeon one specific question. What does the evidence say about arthroscopy versus supervised rehabilitation for my specific condition? If the answer does not include the Moseley trial, you have not yet had the conversation you need to have. Stay with me, because Operation 2 involves one of the most performed procedures on seniors with back pain, and the evidence behind it will genuinely alarm you. Operation 2. Lumbar spinal fusion. For nonspecific chronic back pain, the operation with a 30% failure rate. Lumbar spinal fusion takes 2 or more vertebrae, the bones of the lower spine, and permanently joins them together using metal hardware and bone graft material. The logic is straightforward. If the motion between 2 vertebrae is causing pain, eliminate the motion. The problem is that for the most common reason seniors are offered this surgery, nonspecific chronic low back pain without clear structural cause, the evidence does not support that logic. A randomized controlled trial published in the British Medical Journal, Fairbank and colleagues, compared spinal fusion surgery directly against an intensive rehabilitation program for adults with chronic low back pain. At 2-year follow-up, the surgery group showed modest improvement. The rehabilitation group showed comparable improvement. The difference between the two groups was not statistically significant for the primary outcomes. What was significant was the complication profile of the surgical group: hardware failure, infection, adjacent segment disease, a condition where the vertebrae above and below the fusion begin to degenerate faster because they are now absorbing all the motion the fused segment can no longer perform. A 2016 systematic review published in the European Spine Journal estimated the adjacent segment disease rate at 19% within 10 years of lumbar fusion surgery. For seniors specifically, a study published in Spine Journal confirmed that adults over 65 undergoing lumbar fusion face significantly higher rates of post-operative complication, including wound infection, hardware loosening, and prolonged delirium, the latter affecting cognitive function for weeks to months post-operatively. Here is what actually works: a structured program combining targeted core stabilization exercise, manual therapy, and cognitive behavioral therapy for pain management, published in the Annals of Internal Medicine, produces equivalent functional outcomes to lumbar fusion for nonspecific chronic back pain, without the hardware, without the adjacent segment risk, and without the post-anesthesia cognitive consequences that are specifically dangerous for the aging brain. Operation 3. Cardiac stenting for stable angina, the trial that shocked cardiology. A coronary stent is a small metal scaffold placed inside a narrowed coronary artery to hold it open and restore blood flow. For a heart attack, when an artery is acutely blocked and heart muscle is dying, stenting is unambiguously life-saving. I want to be absolutely clear about that, but that is not the context I am addressing here. I am addressing stenting for stable angina. Chest pain that occurs predictably during physical exertion is relieved by rest and represents a chronic narrowing rather than an acute blockage. And for this indication, a 2017 trial published in The Lancet changed the conversation in cardiology permanently. The Orbita trial, Al-Lamy, Francis, and colleagues, performed something that had never been done in cardiology before. They conducted a sham-controlled trial of coronary stenting for stable angina. Patients were catheterized. The procedure looked and felt identical in both groups. Half received actual stent placement. Half received the catheter insertion, the preparation, the recovery, but no stent. 6 weeks later, exercise capacity, symptom frequency, and quality of life scores were identical between the real stent group and the sham group. The stent produced no measurable benefit over placebo for symptom relief in stable angina. For seniors specifically, the complication profile of stenting in adults over 70 includes significantly elevated rates of contrast-induced kidney injury, documented in the Journal of the American College of Cardiology, and bleeding complications from the mandatory dual antiplatelet therapy that follows stent placement, which is particularly dangerous in seniors already taking blood thinners for other conditions. Here is what actually works. Optimal medical therapy, a combination of beta blockers, calcium channel antagonists, and long-acting nitrates, combined with a cardiac rehabilitation exercise program, produces symptom control in stable angina equivalent to or better than stenting without the procedural risk. This is the current recommendation of both the American Heart Association and the European Society of Cardiology guidelines for stable coronary disease. Before agreeing to elective stenting for stable angina, ask your cardiologist, have we exhausted optimal medical therapy and supervised cardiac rehabilitation first? Operation 4. Vertebroplasty. For osteoporotic compression fractures, 2 sham trials, 1 conclusion. Vertebroplasty is a procedure in which bone cement is injected directly into a vertebra that has collapsed due to osteoporosis. The bone crumbles, not dramatically but progressively, under the force of normal body weight. The cement fills the space and hardens, supposedly stabilizing the fractured segment and relieving pain. It is performed on hundreds of thousands of Americans annually. The majority of them are women over 65 with osteoporosis. And in 2009, 2 sham-controlled trials published simultaneously in the New England Journal of Medicine produced findings that should have fundamentally altered the practice of vertebroplasty, and largely did not. Kalmus and colleagues at the Mayo Clinic randomly assigned patients with painful osteoporotic vertebral fractures to receive either real vertebroplasty or a sham procedure, where the needle was inserted and a small amount of local anesthetic was applied, but no cement was injected. Buchbinder and colleagues in Australia conducted an independent trial with identical design. Both trials reached the same conclusion. Patients who received the sham procedure improved at identical rates to patients who received real cement injection. Pain scores, disability scores, quality of life at 1 month and 3 months, identical. A subsequent systematic review published in JAMA Internal Medicine confirmed these findings across the accumulated literature. For seniors specifically, vertebroplasty carries a specific risk that the aging spine is uniquely vulnerable to cement leakage into the spinal canal or into adjacent vertebral veins, which can cause neurological damage or pulmonary embolism. A review in Radiology Journal estimated cement leakage rates of 11 to 73%, depending on technique, with clinical consequences in a meaningful subset of those cases. And there is an additional risk specific to osteoporotic bone. The hardened cement changes how load distributes across adjacent vertebrae. Multiple studies have documented adjacent vertebral fractures occurring within months of vertebroplasty. The very osteoporotic bone next to the repaired segment now bearing forces the repaired segment can no longer absorb. Here is what actually works. Conservative management, controlled activity, targeted analgesic medication, and critically, a supervised progressive loading program that stimulates bone remodeling without compressive risk, produces equivalent pain relief to vertebroplasty at 3 months and superior functional outcomes at 12 months, according to a 2021 Cochrane review. For seniors specifically, resistance exercise, even gentle resistance in the form of wall push-ups and seated leg presses, produces measurable improvements in spinal bone density through the mechanotransduction pathway, reducing the risk of future fractures while the existing one heals. Now, before I reveal what I consider the single most important piece of information in this video, I want you to do one thing. Think about a surgical recommendation you have received or that someone you love has received in the last 2 years. Hold it in your mind, because what I am about to share changes how you should respond to every future surgical recommendation you encounter. In surgical medicine, there is a concept called prehabilitation. It refers to a structured intervention, exercise, nutritional optimization, and psychological preparation, delivered in the weeks before a planned elective surgery, with the goal of reducing post-operative complications and accelerating recovery. The evidence behind it is substantial. A 2014 study published in Anesthesiology, Gillis, Carli, and colleagues at McGill University randomized patients scheduled for major colorectal surgery to either standard preoperative care or a prehabilitation program of moderate aerobic and resistance exercise plus protein supplementation. At 8 weeks post-surgery, the prehabilitation group had recovered functional capacity at twice the rate of the standard care group. A 2019 meta-analysis in the British Journal of Sports Medicine, covering 35 randomized controlled trials, confirmed that prehabilitation reduces post-surgical complication rates by an average of 44% across multiple surgical specialties. For seniors specifically, sarcopenic patients, those with significant age-related muscle loss, face complication rates 2.3 times higher than well-muscled patients undergoing identical procedures. Research published in JAMA Surgery confirmed that improving muscle mass and functional capacity before surgery dramatically narrows this gap. This is the part the surgical system has no incentive to tell you. Because here is what happens in the prehabilitation literature that nobody in an operating room has any financial interest in discussing. A significant proportion of patients enrolled in prehabilitation programs improve so dramatically over 6 to 8 weeks that they no longer meet the clinical threshold for surgery. Their pain decreases below the level that justified the operation. Their functional scores improve past the point at which surgery produces incremental benefit. Their surgeons, looking at updated assessments, postpone, reduce, or cancel the planned procedure entirely. A study published in the Journal of Bone and Joint Surgery, specifically examining patients scheduled for total knee replacement, found that 44% of participants who completed a structured prehabilitation protocol canceled or indefinitely postponed their surgery after experiencing functional improvement that exceeded their surgical threshold. 44%. The preparation for the surgery made the surgery unnecessary. This is not wishful thinking or alternative medicine. This is published surgical research in peer-reviewed journals, and here is what you need to know to apply it. The Senior Prehabilitation Protocol, 8 weeks. Weeks 1 and 2, baseline assessment only. Walk 30 minutes daily. Identify your functional floor. What you can currently do without pain. How far you can walk. How many stairs you can climb. Weeks 3 through 6. Add resistance. Wall sit holds of 30 seconds, progressing to 60. Seated leg extensions with light ankle weights. Standing balance work. The goal is not fitness. The goal is functional threshold. Moving the baseline of what your body can do without surgical intervention. Weeks 7 and 8. Reassess. Compare your functional capacity at week 8 to your functional capacity at week 1. Present that comparison to your surgeon with this direct question. Given this improvement, is the surgical indication still the same? And before any elective surgery, regardless of type, these are the 3 questions every senior must ask. Question 1. What happens if I decline this operation and pursue structured rehabilitation for 8 weeks? What changes clinically? Question 2. What is the published complication rate for this specific procedure in adults over 65? Not adults in general. Adults my age? Question 3. What does the peer-reviewed literature say about non-surgical alternatives for my specific diagnosis? If your surgeon cannot answer all 3 questions clearly and specifically, find a surgeon who can. The best operation, as the oldest principle in medicine states, is the one that turns out to be unnecessary, and with 8 weeks of the right preparation, more surgeries than you would believe end up in that category. I want to hear from you directly. How old are you? And have you been recommended a surgery in the last year? Leave your age and the procedure in the comments below. I read every single one, and this community shapes everything I create next. If someone you love is over 60 and facing a surgical recommendation they are not sure about, share this video with them today. The conversation they have with their surgeon after watching this will be a different conversation. Now, if you have already had surgery and are dealing with post-operative pain, stiffness, or fatigue that your physician cannot fully explain, there is one specific biological process that occurs in every senior body after surgical trauma, and that almost no post-operative protocol addresses. Watch this video next. What I reveal about post-surgical recovery after 60 will change how you approach every day of your rehabilitation.